after. Thank you.
A remarkable reduction in that. I may not have the figures right away, but His Excellency the Governor. In order for everyone to start asking, from 2010, this has been the context in which health.
Well, there's a paradox. We complain that we do not have enough health workers in our facilities. It is true. I gave you a ratio of 14 to 10,000. Why is it that we have very many nurses who have been trained coming out of the nursing and medical colleges, yet we have shortage in our facilities? It is a question of affordability. It is a question of funding to health. While we are complaining, we are having a brain drain of doctors and nurses who are going to Western world. We as a government are not able to afford to employ them because we do not have the resources. Recently, I advertised for a position of 30 nurses in my county. I got application of 667. And those are not working in any other facility. Those, because we say in the application, ensure that you're jobless. Those are the ones you give. So you have very many nurses at home. Some of them have been there for 2 years, 3 years, and therefore, by the time we hire them, they also need refresher courses, Professor Kanyinga. So when you are tailoring this program, you should have a refresher course for those who stay at home for a longer time before they are taken for employment. Because it's there in Kenya. Whether they're going out of this country, whether they're coming to our facilities, they need refresher training. The devolution era has yielded significant results in this regard, increasing access for mothers and reducing morbidity and mobility for both the mother and the baby. With 89% of mothers currently delivering under skilled care in Kenya, as compared to 66% before devolution, that is before 2010. There has been a rapid decline in maternal and child mortality rates, and I would say that between 2014 and 2022, Kenya's under 5 mortality rate reduced from 52 deaths per 1,000 births to 41 deaths per 1,000 births, and the infant mortality rate from 39 to 32 during the same period per 1,000. There is a big lacuna in the program in that while those doctors go on study leave, they continue drawing salaries from the county governments, who at that particular time have a gap because of the absence, and they need to hire other doctors to replace them while they're on study leave. That becomes a double burden for the counties. You pay doctors who are away, and at the same time you're supposed to hire those who are supposed to replace them with very many resources from the counties. In that space, we are requesting that the national government should be able to, or the ministry, like I said, we have one government approach. The ministry, as much as they're doing the tuition or they're paying for the tuition, they should also be able to pay for the salaries for those doctors while they're away. That gives an opportunity for the counties to cover for the gap that they leave while they are on the study leave. I gave an example the other day, and I still do the same. I don't want to talk about other counties. I have 36 doctors in Tharaka Nithi County currently. 14 are on study leave. Therefore, it means I have on record 36, but physically I only have 36 minus 14, and I am paying for their salaries. Can I afford to have other doctors to replace them? That's a question for another day, because your answer is as good as mine. But the specialization, the specialized health workers, like the postgraduate doctors, we have a big shortage in Africa. And that is why today in the Kenyan scenario, and I say this in public, we have, for example, have only 60 oncologists in Kenya with a population of almost 60 million. Why is it that we cannot emphasize on having those specialists in Kenya as much as we are focusing the lower Kanda? I have been looking for a radiologist for Tharaka Nithi for the last 3 months without any success, since my Cuban radiologist left. And we, as much as we are even offering very high salary, we have not been able to attract any because my county is rural. So the issue of the urban doctors again is affecting us because they would prefer to read the images from Nairobi while we are based in Tharaka Nithi, and that professionally will not yield a lot of results because as much as you read the images, you also need to look at the patient to know whether it is true, and even the equipment that have been used to take those images. So there's a mismatch. We need also to focus on training on higher career doctors.